Okay, so we begin our seminar today with Umar Kita Al-Fatihah. Okay, can you hear me?
Yes, can hear you.
Okay, so I will be presenting on the pale children. Eh, sorry, ada technical. So I'm Dayang, so I will be presenting on about the pale children. So okay, this is the first case. We have a 13 years old girl with non-medical illness. So she was presented with worsening pallor and lethargy. So upon further questioning, she had anemic symptoms since 2 years ago, where she had symptoms of lethargy, shortness of breath, dizziness, palpitation, and also blurry of vision. So on diet history, she said that she only eat rice and potato soup since childhood. She also has a family history of thalassemia, where her uncle was diagnosed with thalassemia. However, she was unsure of the parent thalassemia status, but she claimed that her father has similar symptoms as her. Otherwise, she denied having jaundice, or there is no history of blood loss like menses, hematemesis, renal or gastritis. And she also denied having history of connective tissue disease and symptoms like malariash or oral ulcer. So from this case, we can think of certain diagnosis of anemia, probably like IDA or thalassemia, right? So first we need to understand what is anemia. So anemia. So anemia is can be defined as reduction in the RBC mass or there is reduction in the hemoglobin. So for the hemoglobin level, it is vary according to the age of the patient. So it can be divided into several causes, whether the patient is having an impaired red cell production, like the patient has red cell aplasia, or there is ineffective erythropoiesis like IDA or folic acid deficiency. It can also be due to the increase in red cell destruction or hemolysis, for example, like red cell membrane disorder, red cell enzyme disorder, or hemoglobinopathy. Or the patient is having blood loss, for example, like chronic GI blood loss or inherited bleeding disorder. So, okay. So, okay, I would like to include, we know there is a lot of causes for the anemia. So I will be focused.
Sorry, Dayang, I can't hear you.
Sorry, Dayang, I think you are mute.
So for the hereditary stereocytosis, it is a defective in the structural protein, which is pectin. So when there is a defect in the structural protein, so it will cause the structure of the RBC to be unstable and it is osmotically fragile. So two thirds of the hereditary stereocytosis is autosomal dominant, while one third of it is autosomal recessive. So it is quite common lah and we can see it quite common lah in this region kan. So because of this osmotically fragile spheroidal RBC, it has a short lifespan because it will be destroyed. Insulin rapidly as compared to the normal RBC. So they can be presented with anemia, on and off jaundice, hemolytic crisis, having a pigmented gallstone, aplastic crisis when they have a parvovirus infection, and rarely they can have like ulcers, spinocerebellar ataxia, myopathy, and also extramedullary hematopoiesis. So when to suspect whether the patient is having spherocytosis is when we do the investigation, we can see reticulocytosis, microspherocyte feature, osmotic predictor is high, normal antiglobulin test, NKT is elevated, and there is increasing of hemolysis. Okay. So when we see a patient with anemia, so we need to, how do we want to approach them? Is first we need to ask about the history, for the symptom of anemia, what are the causes of the anemia, and also we need to assess the risk factor and also the complication. Then we will do physical examination to look any specific features which can help us to diagnose them, and then proceed with investigation to confirm the diagnosis. And next, we will manage the patient accordingly. So this is the algorithm that is being given in the PBS protocol. So they divide the cause of anemia, they divide it with whether the patient has hepatosplenomegaly or not. And then for the history, first we need to ask about the age, because different disease has different age presentation. And then also we need to ask about the sex, because some sex has also have a different presentation and also disease. For example, like male, they tend to have CPD or sideroblastic whereas for female, they commonly have IgA. And next, we need to ask about the ADCC or REX, because for example, like in Malaysia or Southeast Asia, thalassemia and IgA is quite prevalent. Okay, the table here show the causes of anemia in different age. So for example, during birth, we can suspect the patient to be anemia can be because of physiological or pathological or even iatrogenic. From 3 to 6 months, we can suspect the patient to have hemoglobinopathy, like thalassemia, whereas from 6 months and above, usually they become anemic because of iron deficiency anemia. Okay, so we also need to ask for the history, right, including the other symptom of anemia, and we need to find the cause, whether it is because of hemolysis or if the patient has symptom of bleeding, and also pica. So pica is an intense craving to non-food items. Usually they will have a craving to the eyes, or in children they will eat anything like soil or any non-food object. So it is a pathognomonic for IgA. We also need to ask about their past medical history, like birth history or any previous admission into the similar symptoms, and also traveling history to rule out other causes of anemia. So we need also to ask about the drug history, if there is any family history of similar symptom or that have diagnosed of hemolytic anemia or thalassemia, about the diet history, because iron deficiency anemia can be because of the reducing iron food with iron content. And then we need to also look for the developmental history, because delay in the developmental milestone can be seen in those with IgA, lymphocyticity, and also Fanconi anemia. For the nutritional history, for the infant, we need to ask the type of the milk that they ingest, because whether they take breast milk or formula milk, because although the breast milk has low iron content as compared to the formula milk, the breast milk, the absorption of the iron from the breast milk is better as compared to the formula milk. So usually those who take the formula milk can have a tendency to have IgA lah. And then for the children, so we need to ask about the diet history, whether they take dietary source which contain high iron or not. So for the physical examination, generally we need to look for the symptom like lethargy, fatigue, tachycardia, or of course, cell and jaundice. And then enterochromatic because some of them can have activity symptoms. And then for the skin, because certain skin condition is associated with certain diseases related to anemia. And then for the vaccine, example like thalassemia vaccine, where they can have frontal blocking, prominent smeller, and also easily bond. And then we need to look for the eye. So this is among the certain presentation of Fanconi anemia, also the Diamond-Blackfan anemia. It is quite rare, but it is a chronic disease now. So for the mouth, we can look for the glossitis or angular spondylitis for IgA or vitamin B deficiency. We can look at the chest to look if there is any abnormality. So we can look at the hand for the spoon nail or metaplasia or the tina eminence, which indicate Fanconi anemia. And also for the abdomen, we need to look for hepatosplenomegaly. So after that, we need to proceed. We can proceed with investigation. So most important investigation is we have to do the FBC and also the full blood picture. So in FBC, we need to look for the Menzel index to differentiate whether the patient is having IgA or thalassemia. So this is the HB level according to the age. And this is the full blood picture that can help us to look whether the patient is having hypochromic microcytic anemia, which can indicate thalassemia or IgA, presence of white cell or antibody in the CCD, and also stereotypes. For the, we need also to look for the iron profile to confirm whether the patient is having IgA or in thalassemia, they can have iron overload, and then stool for blood loss and OVA and FIS to look for the rule out the GI blood loss, and also liver function test to look for the bilirubin level because some of them can come with anemia and also hyperbilirubinemia because of change in the destruction. And to rule out thalassemia, we can do hemoglobin electrophoresis and also DNA analysis. So in iron profile, each test can help us to diagnose whether they are having IgA, thalassemia, or anemia in chronic disease. Can you see this center? So this is the thalassemia test that we can do to help us diagnose whether the patient is having thalassemia A or B. Alpha beta sorry. And then this is the test which is direct test and indirect test to confirm whether the patient is having hemolytic anemia or not. So this one is okay. So the table here show the causes of anemia in certain age, including the specific clinical manifestation and also specific investigation findings. So for the management, I will only focus on management of IgA, stereocytosis, and also thalassemia. So for the IgA, of course, first we need to treat the patient according to the cause of the IgA, and then we need to maintain the nutrition. And if the patient still have persist despite of nutrition, maintaining the nutrition, we can give them with iron. So okay, we also need to encourage them accordingly for the diet. So for the blood transfusion, usually we won't give the patient blood transfusion unless they are having complication like heart failure or they are severely symptomatic. Okay. So for the management of hereditary stereocytosis, usually we will do splenectomy because they can have very massive hepatosplenomegaly. Other than splenectomy, we need to also the patient also need to take vaccination and also oral penicillin for life. Next is for the management of thalassemia. So it includes the blood transfusion especially for those with transfusion dependent thalassemia. Iron chelation therapy because they have a risk of receiving iron overload. splenectomy when they have presentation of splenomegaly, and then definitive treatment will be bone marrow transplant, but it depends on the patient condition as well. And then diet as well as supplementation to maintain the patient condition. So this is so this is the indication of the blood transfusion. It is later. And then for the iron chelation therapy, usually we will give them with parenteral. But if the patient is contraindicated, then we can give them with oral. Then splenectomy, when they presented with hypersplenism, bone marrow transplant will be done if patient have a compatible sibling. And then we need to assess them using the Pesaro risk group. And then, of course, we need to maintain their diet. We need to add supplements, including the vitamin E, calcium, and zinc. And we need to ask them to not taking any iron-rich food. So that's all for me. Thank you. Any questions?
Any question from the team? Thalassemia is very common, Thalassemia is very common, It's among the disease that we expect you to know in great detail. So if you have a patient, if you get thalassemia in your exam, many students think it's easy because the examination is usually general examination and abdominal examination. But the thing is, if you get thalassemia, we expect you to know in great detail. All the complications of thalassemia, all the problems with iron chelation and so on and so forth. So we expect you to know in great detail. Okay. All right. If there's no question, then proceed.
So next I will be presenting about how we do this. You guys can see. Yeah. So, firstly, what is the definition of easy breathing? So, easy breathing can be defined as breathing without history of trauma. Or breathing after minor trauma that do not have caused breathing in the past, and a bruise, also known as echinosis in problem, which is a collection of blood beneath the skin resulting from extravasation of blood from the surrounding vessels. So actually how a bruise occurs, when there is a physical injury to a blood vessel, normally it will trigger a physiological response, which is the coagulation cascade, right? So first, when there is a damage to the endothelial tissue, it will activate the platelet and also the bond factor. And this in turn then there will be a stabilization via cable deposition that will result from activation of the coagulation cascade. So if there is any problem or defect at any step of the process, it will increase of abnormality and disease, regardless of the degree of the trauma, whether it's minor or major trauma. So next, these are the causes of bleeding, which can be divided into hematological and non-hematological according to NAS's potential. So in hematological, we can divide further into thrombocytopenia and also coagulopathy. In thrombocytopenia, we can divide into primary and secondary cause. In primary, the most common one is ICC, and secondary can be others like malignancy, anemia, DIC, and blood disease, sepsis, HUS. And for coagulopathy, we have primary cause is bone membrane factor deficiency and hemophilia. Secondary cause can be also DIC. DIC presented with bleeding and coagulopathy. Next, non-hematological cause that we should not forget, which is the main one is childhood disease other than trauma. So we have a case study, 5-year-old Malay boy presented with a complaint of bleeding for the past 1 month duration. So I would like to ask the floor, what were the history that you would like to ask? So I have a representative from group 1 to ask what were the history that you would like to ask. Maybe we can have Alisa. Alisa is talking.
Hello?
Yes, we can hear you.
Hello?
Yes, Alisa.
Oh, okay. So I would like to ask, and is there any any bleeding punya ni tendency, maksudnya dia apa ni gum bleeding ataupun hematrosis tu semua.
So initially we can answer this for the patient. First, the H1 sex, whether it's a congenital versus acquired problem. And for associated trauma, is there any history of non-accidental injury or any history of physical injury? And then there is where is the site of the multiple, where is the site of the bleeding, whether it's a multiple area of the body or only confined to a specific area. And then we can ask the severity, whether it's a generalized bruises or only a small bruises. So if it's generalized or larger size bruises, it's most likely due to mechanical disorder. And then in bleeding, as mentioned by Alisa, any bleeding history such as epistaxis, gum bleeding, gastrointestinal bleeding, and also hematosis, which can be specific for hematological diseases like hemophilia. And next, gut history, which can induce the bleeding tendency such as NSAID, anticoagulant, antiplatelet, and glucocorticoid. Next, in diet history, those children with dietary protein or vitamin C deficiency may have a bleeding tendency, and a lucky family history a family with only males affected suggested acting disorders such as hemophilia, factor gastritis, or factor deficiency. And by contrast, a family with males and females affected equally suggest an autosomal disorders such as non-mutant factor disease. So on certain history, this patient, he was born at term with no complication. The bruising started 1 month ago and it can be seen all over for generalized. And he has a history of gum bleeding when brushing his teeth every day. And mother also complained that the child has 2 episodes of epilepsy for the past 9 months. He was sent to nursery every day as both parents of his parents is working. However, mother denied any history of trauma for the past 1 month. Otherwise, he has no history of hematological disorders running in his family and no history of taking any food tablets, any anticoagulant, and food and everything. So, what are the clinical findings that you want to elicit in this patient? So maybe we can have any representation from group 2, Media or Farhani. What are the clinical findings that you want to elicit in this patient?
So for general examination, I would like to look for is there any sign of anemia such as conjunctival pallor, and then I would like to look for the evidence of bruises because as mentioned before, patient presented with bruises, right? So for the bruises, we look for the whole body lah, for the bruises too, and then is there any other sign of bleeding? For instance, petechiae, and then for the abdominal examination, I would like to look for is there any hepatosplenomegaly? I think.
Okay, thank you. Thank you, Olivia. So in patient, when as mentioned, the examination we use the one for the whether this patient is weak or active child. And then the appearance and distribution of the bruises, which we can differentiate whether it's the physical abuse bruises or just due to a hematological from the distribution. And also we need to find any other sign of bleeding, petechiae, purpura, hematosis, hematosis or hemophilia. Abdominal examination, hepatosplenomegaly in multiple type of hematological malignancy. And however, in IPC, immune thrombocytopenic purpura is absent of hepatosplenomegaly. And then joint examination, as mentioned, hematosis. And also a specific known specific disease is allodynic syndrome, which is non-hematological cause. It is presented with hypermobile joint or skin hyperelasticity. Other examination we can rule out by doing lymph examination, palpate the lymph node, vitamin node, the axillary lymph node, or the which means suggest any lymphadenopathy which suggests lymphadenopathy or infection. So on physical examination, we shall lie into find the patient who's looking very weak and there is a congenital epilepsy. Most state that is multiple bruises in the abdomen and upper limb. There is also right knee joint fusion and tenderness, which may suggest that patient having hematosis. Otherwise, no lymphadenopathy and no hepatosplenomegaly. So next, what is the immediate investigation that you want to do for this boy? Maybe we can have a representative from group 3, 4, 5. Any volunteers? Not any calling anyone. Ayman?
Maybe we can do first investigation. I would like to do the full blood count, and also to look for any normal the hemoglobin count, whether there's anemia, or the platelet count, whether there's thrombocytopenia. Next, I would like to do also the coagulation profile to look for the PT and also APTT for any prolong in time. And then I would like also to do other essay, factor essay like factor 8, factor 10 and also factor 9 and also factor 10. Factor 9 and also factor 10.
So in patients with bleeding, first we can do full blood count, which can be the patient might have a normal full blood count result, anemia or thrombocytopenia. So normally if the result may came normal, we will be patient having a physical age. So anemia or thrombocytopenia may suggest any history of hematological disorder. Next, peripheral blood film may have abnormal platelet size or a normal platelet size. So if there is a giant platelet size, it may suggest the patient having ICC. And then for ovulation profile, we can look at the CT, corresponding time, and activated partial thrombocytopenia time. It can be normal or prolonged. And then next, specifically factor AC, factor 8 and factor 9, and also factor AC for 1 milligram factor. So any deficiency in factor 8 will suggest of hemophilia, factor 9 also hemophilia B, 1 milligram factor for 1 milligram B. And then next, 1 milligram factor antigen for 1 milligram B, specifically for factor AC also for hemophilia. So let us start. Common cases that are recovered on the three cases, ICC, hemophilia, and also one. So first, ICC is an autoimmune, so which there is antibody that affect the platelet that can result in thrombocytopenia and prevent platelet disease such as Ebola and also the classification of ICC according to the protocol can be specified into a newly diagnosed ICC, resistant ICC, chronic ICC, and severe ICC. It depends on the degradation. Next, summary. Is that, can you hear me? Is it echoing? Is it still echoing? That I report. So these are the summary of human thrombocytopenia. So for ICP, commonly presented as absence of pathogenomegaly or lymphadenopathy. And in peripheral blood film, we can find there is a larger area. So in treatment, we can first advise the patient. It can, as ICT can limit spontaneously, and we can consider hospitalization when the patient presented as a severe form, such as intravenous hemorrhage, and the platelet count is less than 70% or without bleeding. And we need to give advice precaution with physical activities, such as avoid contact sport, any avoid taking any aspirin and liquid, and seek immediate treatment if it is if there is. And lastly, what is the choice of treatment can give to them is oral prednisolone. According first 2 milligrams per day for 14 days, and then taper off over 5 days. And then continue oral prednisolone 4 milligrams per day for 3 to 4 days. And also the treatment option is ICID for 14 days. Can I ask Doctor regarding the choice of treatment, what does it mean by oral prednisolone 2 milligrams, and then we taper off for 5 days, and then next is oral prednisolone 4 milligrams for 3 to 4 days. If we continue or include the different regimen.
Again, what's the question?
In each protocol, it mentions oral prednisolone 2 milligrams per day for 14 days, and then we taper off over 5 days. And then number 2, oral prednisolone 4 milligrams per day for 3 to 4 days. Is it a continuation or a different regimen?
No, I think it's either lah. You can do either lower dose at a longer duration, or you can do another option that you can do is actually you give higher dose but shorter duration. So that's the option that you can do.
So since ITP is autoimmune, you can give ITP.
One thing I need to remind everyone, I've seen before cases where we advise patient properly, but one thing we forget is the school, because children has many things in school. We advise about physical activities and so on and so forth, but one thing we forget was there are other things happening in school. For example, one of my patient before came in with ITP, and then we discharged after 1 week, admitted again with hemiparesis, proper hemiparesis, because there's bleeding, there's intracranial bleeding. So what happened was there's a dental procedure in school. So, and we didn't advise properly to the parents and to the teacher that yes, they understood they cannot do physical activities, but they do not understand that seeking this sort of treatment is also not okay. So the child had dental extraction. So that then bleeding from dental extraction can stop, but it took a bit longer time to stop. But the problem is all the remaining platelets are actually used up to stop the bleeding in the teeth. So what happened next is intracranial bleed. So that's one thing. When we advise patient, we do need to advise properly, completely, and thoroughly.
So next is hemophilia. So hemophilia is actually recessive inheritance. So, but the percent as spontaneous mutation. So hemophilia can be divided into two types: hemophilia A and hemophilia B, which will be deficiency in factor 8 for hemophilia A, deficiency of factor 9 in hemophilia B, which also known as Christmas disease. So, for confirmatory diagnostic investigation, we can look at the specific and it's important for hepatitis screening because from the treatment, patient might have a high risk of acquiring virus infection from the which will give factor 8 or factor 9 percentage So, and then from the presentation, we can see that the patient having easy bleeding at the age of 9 when they start crawling and walking, as there is a injury, hematosis, in hepatitis, some bleeding hemophilia, bleeding, and in severe is and also spontaneous bleeding after trauma, as mentioned before, such as a dental procedure or surgery. This is actually effective how the transmission. So hemophilia A with a presentation of massive hemorrhage, a big ecchymosis and also gross swelling from hematosis of the joint. Next, last part, von Willebrand disease. So what is it? Von Willebrand disease. When a disease that affected both male and female equally, which means there is also autosomal dominant inheritance. So there is several types of von Willebrand disease. So type 1, there is a type 1, type 2, and type 3. And the presentation also different and variable according to the type that you can relate to. Maybe you guys can see from the diagram. One Willebrand factor will be released when there is a traumatic endothelial injury that will activate the platelet aggregation, and also at the platelet also there is a one Willebrand factor that will more aggregate the platelet and make the coagulation activate the coagulation pathway. So when there is a deficiency, then there will be bleeding, and continuous bleeding presents with a bleeding certificate. So in one Willebrand disease, we can specifically investigate for the one Willebrand factor axis, one Willebrand factor antigen, which we suspect there is a low number of one Willebrand factor, and also factor VIII, because in one Willebrand factor there is also a release of factor VIII. So that's why we have also deficiency in factor VIII in one Willebrand disease. So specifically, other investigation is research in induced platelet aggregation, in which patient will be given this first thing, and if there is no platelet aggregation, means there is a deficiency in one Willebrand factor. Lastly, what is the treatment we can give the patient? First, desmopressin. It is more effective for type 1 and type 2 one Willebrand factor deficiency, as there is a three type. And then we can give also one Willebrand factor complex, effective in type 3, because type 3 presented in severe form. And then next is anti-fibrinolytic for adjuvant for oral bleeding. And lastly, can give cardiovascular and fresh frozen plasma. And however, we need to check for virus screening, as there is risk of viral infection in cardiovascular and fresh frozen plasma. And lastly, we need to advise the patient doing all the activities and using of aspirin and NSAID, which may induce with bleeding. Any questions?
Any question? Tak ada. Semua tak larat dah. Puasa. Okay lah. Alright, fine. Proceed. Hemophilia is another favorite question for exam. Theory lah, theory. OSCE, it's so easy to make question about hemophilia. Okay, alright, next presentation.
Okay, I'll proceed to the last topic for problem-based seminar today. Child, next slide, which is a child with jaundice. Next slide. Next slide. Okay, this is the only case study that I provide. 4-year-old boy was referred to emergency department due to jaundice for 1 day. So how do we approach? Of course, by history, physical examination, and also investigation. So as the Doctor mentioned before, the objective of in every cases, we need to get into provisional diagnosis to rule out any differential complication of the disease and also the treatment as well. Next slide. Okay, so this is one of the way to identify for the cause of the jaundice, which includes a pre-hepatic cause, hepatic, and post-hepatic. So pre-hepatic cause, of course, the problem is with erythrocyte, whether it is acute hemolysis or chronic hemolysis, enzyme-related like in G6PD, membrane defect like spherocytosis or erythrocytosis, sickle cell, thalassemia, IHA, and also microangiopathic hemolytic anemia. And others like infection can also cause pre-hepatic jaundice. And hepatic cause, we can divide into, previous slide, sorry, Dayang. Still in previous slide. So for the hepatic cause, we can divide into acute or chronic. For acute cause, for example, like in acute liver failure or hepatitis, chronic like chronic liver failure lah. Post-hepatic like in biliary atresia and also cholestatic jaundice. So this classification is very helpful because it can trigger us to ask questions related to these 3 causes of jaundice, because there are some features that we can actually give us idea and clue what is going on and what is the cause of the jaundice itself. Next slide. So these are the possible cause of pre-hepatic jaundice, which includes intravascular, for example, like malaria, or in microangiopathic hemolytic anemia. There is a hemolysis occur due to abnormal blood vessel. For extravascular cause, for example, like G6PD, like Dayang mentioned just now, thalassemia, autoimmune hemolytic anemia, hereditary spherocytosis, erythrocytosis, and also sickle cell disease. For infection like mycoplasma pneumonia. Next slide. So these are hepatic cause for jaundice. For example, infection related like in hepatitis B virus, which is common in vertical transmission where the child got from his or her mother lah. And EBV, Epstein-Barr virus, cytomegalovirus, HIV, and also leptospirosis. Metabolic cause, for example, like Gilbert syndrome, where there is a decreased bilirubin uptake by the liver, and also Wilson disease, where the copper accumulates in the liver. Liver can also accumulate in kidneys, brain, and also eyes. Toxic related, for example, like drug induced, like isoniazid anti-TB drugs, and also any paracetamol injection. Autoimmune hepatitis, and others like Crigler-Najjar syndrome, but carry and also Najjar syndrome. Next slide. So these are possible cause of post-hepatic, for example, like biliary atresia, cholelithiasis, secondary to chronic hemolysis, and also tumor or cyst. Okay, next slide. So this is a Kasai procedure where you can see a small intestine is connected to the liver, which can allow the bile flow from the liver to the small intestine. Okay, next slide. So this is just to illustrate the metabolism of bilirubin. Next slide. Next slide. Okay, so these are the questions that we can ask to consider the pre-hepatic cause of jaundice. For example, like anemic symptom, we can ask any lethargy, dizziness, palpitation, or any shortness of breath. Second is abdominal pain, but usually in pre-hepatic cause of jaundice, the abdominal pain is mild. And then hemolytic uremic syndrome, and the triad is a hemolytic anemia, acute kidney injury, and also thrombocytopenia. So you can ask like any bruising, and usually the hemolytic uremic syndrome is preceded by diarrheal illness. So you can ask any abdominal pain, any bloody diarrhea, and also any vomiting. For atypical pneumonia, you can ask a symptom of pneumonia itself, fever, cough, shortness of breath, and also chest pain. And lastly is a G6PD triggering factor, like for example, favavin consumption, medication, and also infection can trigger the G6PD. So these are the pre-hepatic questions. Sorry. Next slide. So for the intrahepatic cause, you can ask any dark urine, any gastrointestinal symptom, for example, like abdominal pain, vomiting, any diarrhea, and also anorexia. We can ask because anorexia can be any features of hepatitis, and also we can consider any metabolic liver disease, and of course, you need to ask fever to know whether it is effective in nature, and also leptospirosis symptoms, for example, like headache, myalgia, conjunctival subfusion, cough pain, skin rash, or any reduced in urine output. And also the risk factor to get the leptospirosis, like for example, history of exposure to the water or ingestion of rodent. And hepatitis risk factor, ask about whether the mother got hepatitis B during pregnancy. Okay, next. So these are the questions for post-hepatic cause that we can consider. We can ask the obstructive jaundice symptom like pale stool, dark urine, any pruritus, fat malabsorption, steatorrhea, any bleeding tendencies, and also constitutive symptoms. Next slide. Okay, for the past medical and surgical history, you can ask any previous jaundice, any neonatal jaundice, and is there any phototherapy was given, any previous history of blood transfusion, which might indicate that this patient have thalassemia, and is there any pre-existing liver disease? If yes, might be due to chronic form of liver problem, like in chronic viral hepatitis B. If there is no pre-existing liver disease, and then you can consider this as acute hepatitis or acute liver failure and if there is any previous abdominal surgery throughout post-hepatic cause jaundice. Next slide. For the drug and allergy history, so you need to ask about any drug that can cause jaundice for example, like anti-TB drug, anticonvulsant drug, paracetamol, toxicity, any supplements, and also prolonged TPN more than 2 or 3 weeks. Next slide. Okay, so for the family history, of course, we need to ask any family history of thalassemia, G6PD deficiency, sickle cell disease, and any metabolic or genetic disorder, for example, like in Wilson disease, any consanguineous marriage, also any viral hepatitis in the family. Next slide. So others like birth history, whether the child was born preterm, nutritional history, growth development of course important because as we know, chronic illness can affect the growth and development, can lead to growth retardation and also failure to thrive, mainly due to malnutrition and poor oral intake and also social history as well. Next slide. So this is a continuation of the case just now, where the history revealed that the patient had palate and vomiting for 1 day, no dark colored urine or pale stool, no fever or loss of appetite, there is a mild abdominal pain. So this is most likely like, we can consider pre-hepatic cause of jaundice. Okay, next slide. Okay, so for physical examination, of course, we need to observe the level of consciousness, whether there is an altered mental status, which can lead to bilirubin and CAF, also bilirubin encephalopathy or hepatic encephalopathy. And we also need to look for any dysmorphic features, to look for any Alagille syndrome, and thalassaemic phases like Dayang's mentioned just now, and also any stigmata of liver disease, any pallor, jaundice or cyanose, any rashes, bruises or scratch mark, lymphadenopathy, stigmata of liver disease like spider nevi, palmar erythema, also clubbing, and we also need to look for any pedal edema lah. Next slide. So this is the Alagille syndrome features. Next slide. This is a thalassaemic phasis. Next slide. Okay, not to forget vital sign, anthropometry measurement, head circumference, also growth chart. Next slide. So specific examination, we need to examine the abdomen to look for any scar, any tenderness, hepatosplenomegaly, ascites, palpable gallbladder, and check also for the respiratory, pleural effusion, also rule out pneumonia, cardiovascular system to rule out any congenital heart disease, and also central nervous system to look for any features of suggestive of Wilson disease. Next slide. So on examination, he appeared ill. There are pallid and deep jaundice. Respiratory is 45 beats per minute, breath per minute, sorry. Blood pressure is 100/70, pulse rate 100/20, per abdomen, no abdominal tenderness. However, there is hepatosplenomegaly. Next slide. So how do we investigate? First, of course, we need to do the full blood count to look for the hemoglobin level, since the patient is pale just now. And if there is anemia, we need to find the cause of the anemia. And we can also look for any anemia of chronic disease as well. And look for reticulocyte count, because if there is any increase in reticulocyte, it may suggest hematological condition. So we might need to proceed with another confirmatory test. And then for full blood count, we need also to look for white cell count, any evidence of infection, of course. Next investigation that we can do is liver function test. So to look for any direct or indirect bilirubin increase in direct or indirect bilirubin. If direct bilirubin is less than 20% of total bilirubin, then we can consider unconjugated cause of jaundice. And then in liver function test, we also need to look for liver enzyme. So if there is any elevation of AST and ALT, may suggest intrahepatic cause, and if there is any increase in ALP and gamma glutamate may suggest of post-hepatic cause of jaundice. In liver function test, we can also look for albumin level. So albumin will be normal in acute liver injury, but it will be reduced in chronic liver disease. Albumin level. Okay, next is renal profile. So why we need to do renal profile? Because some disease can cause GI symptoms just now, like vomiting, diarrhea, so it might lead to dehydration. So we need to look for any urea and creatinine level, which might suggest if there is any evidence of acute kidney injury. And just now, hemolytic uremic syndrome can also cause AKI, and look for any complication of disease like hepatorenal syndrome. In renal profile, we can also look for ammonia level to look for any hepatic encephalopathy, evidence of hepatic encephalopathy. And next investigation, we can do a full blood picture to look for evidence of thalassemia, for example, HB electrophoresis to know the type, fluorescent test, and enzyme to look for G6PD, evidence of G6PD, direct home test for IHA, immune related. Next slide. Osmotic fragility test, hereditary spherocytosis, thyroid function test, for example, in congenital hypothyroidism. Coagulation profile, we might expect there is a prolonged PT, APTT, or INR in liver problem, in acute liver failure. We can also do coagulation profile to look for the severity of liver injury and coagulability in biliary atresia. For urinalysis, pre-hepatic cause, there will be urobilinogen or hemoglobinuria. And for for virus serology, IgM for hepatitis A, HBs antigen for hepatitis B, Hep C virus for hepatitis C. Leptospirosis, we can do microscopic agglutination tests, ANA and ASMA, anti-smooth muscle antibody, mainly for autoimmune hepatitis. Serum ceruloplasmin and urine copper is for Wilson disease. And blood group cross-match is when the child need for any blood transfusion later on. Okay, next slide. So imaging that we can do is ultrasound kidney KUB to look for any evidence of hepatosplenomegaly, features of CLD, which is ascites, and we can also look for any dilatation of the bile duct, any deformity of the duct in biliary atresia. Can also do biopsy in autoimmune hepatitis, Wilson disease. We can also consider chest X-ray throughout any atypical pneumonia, and others like cholangiogram or hepatobiliary scintigraphy, for example, like HIDA scan to check for excretion of bile from the liver into the intestine. Okay, next slide. So this is the result of patient just now. Hemoglobin revealed 4.3, white cell count 9, platelet 270, which is normal lah. HP low, reticulocyte count increase. Total bilirubin and total bilirubin high. Direct bilirubin is less than 20% of total bilirubin lah. This might indicate hemolytic cause of jaundice, pre-hepatic cause of jaundice. LDH is 64, which is quite high, which is suggestive of hemolytic anemia. Urine 4-HB is positive, which is this patient have urobilinogen. Full blood picture is pending. Okay, next slide. So further question revealed that he had eaten fava bean prior to this. During onco review in the ward that night, mother complained that the child had persistent vomiting and appeared lethargy despite giving blood transfusion earlier. So the latest blood investigation revealed the urea 7.8, creatinine 90, potassium 6.0, quite high, sodium 135 normal, chloride 90. Reduced. So there is electrolyte imbalance. So the management, of course, we need to treat the underlying cause and complication, optimize the nutrition, also hydration of the patient, and symptomatic treatment if necessary. Okay, I think that's all for me. Thank you. Any questions?
Anyone? Clear? Any issue?
Doktor nak tanya,
Tanya presenter first.
untuk yang thalassemia tu kan, yang untuk splenectomy, selain daripada vaccination dengan kita bagi penicillin prophylaxis, is there anything else that we give to patient yang buat splenomegaly?
Is there any apa?
Ada benda lain lagi kan yang kita buat untuk patient yang nak buat splenomegaly selain daripada itu?
That's the most important thing lah. Tapi we do need to prepare. Splenectomy is a huge thing. Sebenarnya kita nak kena prepare so many things kan. Make sure patient is well, optimize the hemoglobin and so on and so forth. But that's the main thing lah. That's the main thing. The main thing kita nak kena basically kena prepare is vaccination apa semua.
I have a question. For
Presenter,
thalassemia,
after presenter first.
okay. So for thalassemia patient who require chronic blood transfusion, when we usually do the MRI to detect iron deposition at the liver, at the cardiac.
Mana presenter?
For the monitoring, Okay, so here you can see that we usually will I'm not sure, but I think usually we will meet the patient every 4 weeks because the situation on we require apa ni condition every month. So I think at that time we can also look for the symptom of iron overload.
So basically, it depends lah. It depends, but generally we do need to do MRI like once every 2 or 3 years. The thing is, it's not easy to do those MRI. Sebab you cannot just order any MRI. It must be a specific MRI T2 star. So with MRI T2 star, baru kita boleh tengok dia position dekat brain, cardiac, liver. So generally we do every 2 to 3 years. In some center, they take it 5 years. We in Susmac, we haven't got any patient that we are treating with thalassemia yet.
Okay, thank you, Doctor.
Okay, all right. That's it. Anything else? Okay lah, cukup lah Siap-siap ni. Okay. If there's no more question, let's end our session with Tasbih Kafarah Surah Al-As. Okay, Assalamualaikum.
Thank you,
Salam.
Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Okay, Assalamualaikum.
Assalamualaikum.